Okay. Hi, everyone. We are on live stream now. Thank you for joining this session. This session, we are going to talk about everything that we wish we knew before we deployed our machine learning models. I am Anubhuti Mishra. I am a senior technical advisor for data science with Palladium, and I work on deploying machine learning and data science-based solutions in public health. I primarily work on USAID projects on HIV and COVID-19 across Africa and Latin America. And today on the panel, we have Pascal Muele from Palladium, where he is a program director and leads a CDC-funded health informatics project in Kenya. He has over 15 years of experience in national information technology projects across sub-Saharan Africa. With Palladium, he has been leading the design, testing, and scaling up of machine learning-enabled digital health solutions. And he has a background in computer science, technology strategy development, and project management. Thank you, Pascal, again for joining this panel. Our second panelist is Jenny Stockman, and she is senior manager at MacroEyes and has spent the last decade deploying innovative technologies to challenging political and social environments towards ensuring quality health services that are equitable, efficient, effective, and accepted. She has dual degrees from Johns Hopkins University School of Advanced International Studies and Bloomberg School of Public Health. Again, thank you, Jenny, for joining this panel. Then our third panelist is Mihir Kulkarni from Wadhwani AI, where he is a machine learning scientist and works on predicting adverse outcomes for tuberculosis patients across India. His team recently won a prestigious Outstanding Paper Award at ML for Health at the NeurIPS 2022 conference. He is particularly interested in developing ML-based solutions in healthcare that are robust, interpretable, fair, and sustainable over long periods. And he has an MA in computer science from Princeton and a BTech and MTech from IIT Bombay. Thank you, Mayor, for joining this panel. And we are looking forward to learn from your experience. So without further ado, let's jump in. My first question is to all the panelists. If you could share some insights from your ML project that was shared in this panel description, and if you could talk about some of the biggest roadblocks that you faced in implementing this particular ML project. Pascal, do you want to take it first?
Yeah, thank you very much, Anu, and I'd like to thank the other panelists for making time to discuss this very interesting topic on what I wish someone had told me before I deployed a machine learning model. It's indeed a very wonderful opportunity to share our journey, the challenges, but also the successes that we'd like to share. As a matter of brief background, I oversee the implementation of a CDC PEPFAR-funded project in Kenya that focuses on the deployment of electronic medical record systems across 40 counties in the country. And through these electronic medical record systems, we have a coverage of over 94% of people who are currently on treatment, HIV treatment. And apart from managing the electronic medical record systems, we manage the full data value chain for the HIV program, whereby we manage the transmission of data to a central data warehouse for individual level data, support capacity building, deployment, and sustainability and continuous evolution of the technologies. With that background, we started our journey of developing machine learning models in 2019, if I'm not wrong. And through that, we had a number of use cases. And on case finding, but also on interruption in treatment. And through that, we've looked at the two use cases that I've talked about. We've looked at the maturity of those models to date. And I'm happy to say that we have deployed them and currently supporting the scale up of the two machine learning models. In terms of roadblocks, the first one I'd have to say is just getting the team on board, the program team. Machine learning is a new concept to the program team. So we had to first start from a technical standpoint, building a team that understands the data. And once we had a first prototype built on MATLAB, and just want to make a note that we presented that in the Global Digital Health Forum 2019 on the first prototype that we developed. And we built around that in making sure that the program team was on board. They knew the concept of machine learning and worked with them to deploy the models. So what we've learned out of that is that it's really important to ensure that the program team is on board as the users, taking a very user-centric design and approach, ensure that they understand how machine learning works and how different it is from traditional statistical approach and modeling techniques. The other is around data. Machine learning, to our experience, is probably 70 to 80% data engineering. How you manage your data, how you deploy your models is dependent upon how you understand how the data is collected and how it's used to design the models. So that is something that we've been very privileged to have worked with the program team and the users to build their capacity on understanding the data, but also on understanding the models. So I'll stop there, and probably my colleagues would be share the same, or rather different experiences on how they've taken their journey.
Thanks a lot, Pascal. That was right on time. Jenny, do you want to take up this question?
Yeah, absolutely. Hi, everyone. And again, thank you to the other panelists and to the organizers for joining us, and for everyone to join us at this time, wherever you are in the world. I'm going to speak a little bit about some of our work specifically on interruption and treatment. And that work on interruption and treatment focuses on really leveraging artificial intelligence and machine learning to predict human behavior, specifically helping to answer the question of who's going to show up for an appointment and who won't. Our work is in Mozambique specifically. We've deployed in some other countries, but I'm going to use this as my example today, where we worked with USAID's funded Datafy project to provide predictions on health-seeking behaviors amongst ART clients specifically. To do this, we used publicly available data alongside existing data sets within the health system, and we were able to generate real-time repeatable predictions, which identify with high precision which ART clients are at greatest risk of interruption and treatment amongst USAID-supported facilities in Mozambique. So how did we do this? Well, during the first phase of work, we augmented de-identified client data with other publicly available data sources. And we used that to describe the contextual environment surrounding facilities and the clients themselves. We trained 5 different types of models and then selected the best performing options for each algorithm. The best random forest algorithm outperformed all other models in this case on both precision and recall. And I can obviously go into a lot more detail for anyone who's interested in that in the chat. The benefits of using ML in this instance were evident. Compared with the existing client tracking, our algorithms identified more clients who were likely to become lost to follow-up than the baseline, and they did so with more precision. One thing I want to make very clear, though, is that the results don't suggest a need to abandon current tracking efforts. Rather, they support the hypothesis that machine learning can be a useful aid to help prioritize individual clients. In this case, we deployed our module directly at site level in order to assign a risk of interruption in treatments to existing lists of patients. How it's then used is healthcare workers can use that output to prioritize interventions according to the risk of non-adherence for each client who is scheduled for an appointment in the coming week. And the predictions are then being run in real time, which means that they're updated with each new appointments for each individual clients. High-risk clients, key populations, all of those clients who would normally receive added interventions should continue to receive those. This just allows you to prioritize the order in which you reach out to them. In terms of roadblocks, I absolutely agree with everything Pascal said, and I'm not going to repeat that. I'm instead going to draw on a couple of other key takeaways for us, which kind of hint on some roadblocks as well. First of all, this is related to the data question that you mentioned, Pascal. It's really important for us to use existing data. We don't want to collect new data. We want to develop models that are resilient and scalable. And that means not being reliant on a single source of data and not assuming that the same data is going to be available in every instance. That has been a roadblock in terms of understanding and kind of building that trust for users who may not be as familiar with machine learning and AI. There's often an assumption that the data available has to be like complete and freely available. And one other thing I'll just mention, I know I'm out of time, integration with existing systems. This is a really big challenge, and it was a really big challenge for us in Mozambique. The systems that they were using, the software systems, the data environments was considered vintage, and that was definitely a challenge for us. But we overcame it. And the point there being that there's often an assumption that you have to have the most high-tech environments and data environments already in place, software in place, capacity in place. That's not actually necessarily the case. And I'll stop there. Thank you.
Thanks a lot, Jenny, for sharing that valuable experience with us. Mihir, do you want to take up this question and share your experience?
Yeah. Thank you, Anubhuti, and all the other panelists for having me. So I work at Valdhani AI on a project for predicting adverse outcomes for tuberculosis patients in India. So we know that while TB is treatable, we have several adverse outcomes such as non-adherence, in particular the extreme proxy for non-adherence, which is LFU, where patients don't take medication for 30 days consecutively, which, as we know, is a risk factor for mortality, morbidity, and drug resistance. And so apart from LFU, we're also looking at death right now. In general, proactive identification of patients at risk of adverse outcomes is important, because if you wait till the adverse outcome is closed, then it's often too late. And so we build this tool to help triage healthcare worker allocation, so they can essentially target the right patients to mitigate the adverse outcomes. The summary of our results is that it's quite promising. We spent a lot of time developing these robust and good rule-based baselines, which are the baselines that we developed by talking to domain experts during a wide literature review and codifying, in some sense, what a human following an ideal protocol would implement, which is like a checklist-based baseline. And over those baselines, we do almost twice as well on this custom metric we define, which tries to measure how much coverage you get given a fixed resource allocation. In this process, we also dealt with several issues, such as folks have mentioned, data quality, but also specific to our domain, things like high cardinality categorical data, where you have things like location, which have lots and lots of categories, which could be difficult for the ML model to actually process. We also deal with issues like low target prevalence, in the sense that the adverse outcome is not very prevalent. So on the technical side, this is a challenge. One thing that I'm quite proud of that we did is we did a pretty extensive evaluation, where we evaluated on like 6 months of data of patients across the country, across several key cohorts, such as states, districts, but also non-geographical cohorts, such as type of case, type of healthcare received, gender, and so on. And so this evaluation and like sort of this fairness aspect is related to the not just like responsible AI, which is pretty which is like a buzzword and like something people really care about right now, but also understanding sort of how exactly the model is doing, not just at a high level, but also I think at a granular level, which is important to understand, like contextualized sort of deployment strategies. In terms of the project journey, we started with the proof of concept with around 40,000 patients, stepped up to 700,000 patients from 4 states last year, and most recently we've been working with essentially most TB patients across the country. I would say the thing that I think is really going for us is that we spent a lot of time developing like deep partnerships with the Indian government. And so we're the official AI partner of the Central TB Division of India, which administers the database that stores all the information we use to power our models, called Nikshay. And so we're hoping that once we're doing a pilot soon, and we're hoping that once, if and when that succeeds, we'll have enough sort of evidence to actually integrate our model into the government database, and therefore be essentially added to workflows pan-India, and for which we're planning pilots with local governments, which, and this is like a nice segue to talk about some of the roadblocks that we faced. So I think I am almost out of time. So summarizing the key roadblocks, I think first is technical formulation. So understanding what outcome to predict. Is it LFU? Is it mortality? What do people care about? And like, how do you sort of formulate the problem in a way that actually makes sense on the ground? Obviously data, I think folks have talked about, but in particular missing data, both dealing with missing data and also understanding the sources and the model of errors that could be generated. When it comes to evaluation, adapting some sort of evaluation practices for this context, where there are some variables that are key to sort of measure evaluation across, and understanding the domain from the public health side and sort of taking that to the machine learning side. Finally, on the deployment side, I think tying in with interventions. We know that we want to do interventions, but it's how do you sort of tie in interventions with this like new technical system to an on-ground program that already has some way of how things, has some knowledge of how things are done. And this brings us to user design, user trust. I think Jenny has spent has given us a good insight on. Users often have different assumptions, and you need to design workflows that actually make sense for them. So that's been an iterative and very long process. Finally, I would say getting approvals for the pilot and like working with governments, understanding their side has sometimes been a process of a lot of back and forth. And finally, getting to a pilot has taken us some time, but hopefully we'll be getting there pretty soon. Thank you.
Thanks a lot, Meher. That was extremely insightful. I do have some follow-up questions that I'll bring back at the end, but I do want to move to the next question, which I have for Pascal. And then once he's talked about his experience, I would love to have other panelists also chime in. So Pascal, this is for you. What are some of the key factors, according to you and based on your experience, that can ensure that ML projects are sustainable in medium to longer term?
Thanks, Anu. And I'm really glad to hear from the other panelists, because the approach that we've taken in Kenya are quite similar to what Jenny mentioned under the DataFi project and what Meher also mentioned in his presentation. So in terms of sustainability, the key factors, the first thing I would like to start with is Simon Sinek's start with a why. Why do you want to deploy a machine learning model? Why do you want to have a pilot on machine learning? So rather than just having it because it's the new thing or it's the in thing, you need to have a very clear value proposition as a starting point. And in our case, as we're talking about interruption in treatment or intensive case finding, that is the most important value proposition to make to the users and to the other stakeholders. As you've heard from the other panelists, it's very important to ensure that you have other collaborators, because it's not a technical endeavor. It is a multi stakeholder sort of like an endeavor that you need to make sure that everyone is on the table right from the beginning. The second is the underlying technology, both for the frontline access and for the compute power that you need. I think my observation over the last 2 or so years has been that you need to think about deployment right from the beginning. To Jenny's point, you need to think about how you're going to embed the deployment of ML within the existing processes, within the existing technologies, within so that the level of disruption is very minimal. The other is, if you look at data management processes, that's a really crucial element, because you're working with data. I think Meher mentioned this, that you're working with missing values, I mean, incomplete routine data. So the approach that you take in data management is really crucial. And this is where the other stakeholders and subject matter experts come in, because they help to explain the data. As you develop the model, you need to do that together with a team that generates the data and the program team that understands that data. Technical team capabilities is very crucial for sustainability. So once you have a very clear value proposition, you need to have a very clear setup for the team. It's not enough just to have a statistician on a team and think that you're going to be able to roll out a machine learning project and sustain it. You need a team of data engineers, you need a team of data scientists, statisticians, you need the program team as the subject matter experts, you need the software developers who are going to ensure that it's embedded. So the team capabilities or awareness of the technologies, underlying technologies, is very important. So for instance, as a team, we needed to ensure that the software developers were in the development team, so that as we develop the machine learning models, they can already start thinking about designing how we are going to embed the models into an existing clinical workflow within the EMR. Apart from the technical team, then you need to look at the deployment process, right? And capacity building as an ongoing process, right? So the approach that we took was to ensure that we embed the machine learning in the clinical decision process and the clinical decision workflows, so that then it's not disruptive, or it's not a separate tool that you need to log on to and get the predictions. It needs to be embedded, and it needs to be deployed in a way that consumes that data and improves the model continuously. And then finally, I think it's just a culture of user-centeredness. I think that goes without saying. You start with the why, you continue and end with a user-centered approach. What problem are you solving, and how can you solve it better? And a culture of ensuring that you have data use at the center. I think in the interest of time, I'll stop there and probably hear from my other panelists.
Thanks, Pascal. That was very insightful. I'm curious if Jenny or Meher, you have any comments on that?
Yeah, I think, I agree with everything Pascal has said. I think one thing that's really important to establish is AI and machine learning, it's not a snapshot of a situation like traditional analytics. It's really important to establish that. And that's why this question of sustainability is so important. We're not looking to do a one-time analysis that lasts 6 to 18 months to write a really nice report at the end of it. This is about data use for decision making. It's about leveraging data that you have available to make more informed decisions in real time. It can be future looking, it can be real time, but the point is it's not looking backwards anymore. And I mean, it does sometimes, but the real power of AI and machine learning is that it gets better over time. It learns over time, it gets smarter over time. And with that comes the need for maintenance. And it comes the need for sustainability. And that's why working with governments is really important. Having clearly established roles and responsibilities at a national level are important. Understanding the data you're using is important. Not relying on a single source of data is important. There are so many different things to consider here. The point is, and I think, Pascal, you mentioned this really well, is you have to plan all of this upfront. You don't deploy AI and machine learning without assuming you're going to be deploying AI and machine learning. And that's a really important point that you made.
Yeah, thanks. I found myself agreeing to everything both Pascal and Jenny said, and I don't have much to add. The thing I think I would add is one thing I found working in an org that does have a lot of cross-functional teams is it's very important to sort of get people on the same table, in the sense that a lot of machine learning and say public health people, they have like slightly different worldviews and they sort of approach problems from different angles. But they both really have to understand each other's sort of workflow and what exactly sort of each function does to really make any progress. And that's something we sort of took some time to, I think, get to. But like once we were there, that was like super critical in like getting things ahead. The other thing I would say is that like you need to make sure that the solution works for like every stakeholder. So you have like people at the top level who are like your top bureaucrats who may be looking at like overall metrics of like patients treated and so on. You have like your middle managers who are like running like these like local sort of health centers and so on, and their life needs to be easier. the life of the healthcare worker needs to be easier. Like if you have an app, it shouldn't like, be like stressful, or it shouldn't, be like a pain to use. And finally, of course, we're all in this field to help the patient. And so we should make sure that patients benefit. And that sounds obvious, but sometimes that can get lost in a lot of the discussions that happen around like making process more efficient. So I think focusing on like all stakeholders at all times is important. I guess finally, is like understanding the machine learning point of view, which is that deployment is different from pilots. And so you have like a snapshot, as Denny said, but once you deploy, you have to keep on retraining, you have to keep on logging, you need to make sure you're monitoring it for errors. And deploying a machine learning model is its own sort of skill, which is sort of separate from like building the model and sort of showing the initial results. Thank you.
Sorry, I could not figure out how to unmute myself. Thank you, everyone. That was extremely insightful. It seems like everybody agrees on, thinking through the sustainability and deployment process at the very beginning, and thinking about users and the why of, why you're solving this problem, why are you building this ML model, keeping that at the core of the entire work, thinking about every level of users who's involved in the process, from your top level bureaucrats down to local healthcare workers, is very important. I am curious though, I know we have to move on to the next question, but I'm curious when you talk about, Mihir, you mentioned difference between deploying is very different from piloting. Oftentimes when we go into these public health settings, it's an uphill battle to convince bureaucrats or government agencies to even let us try something. So in those scenarios, when you are just trying to get your foot into the door to just build a pilot, is it still important to think about that long term, or do all of you approach the problem, let's get this one thing done, show the value in this particular work, and then think about deployment and
Right.
sustainability?
I do think it's important to think of it from day one, and I think it's not just because you might want to like get something working and then thinking about like long-term things later is non-ideal. But I think the main thing is that like in public health, you can't like get like super fast feedback, right? So like every bit of information you get at each stage is super critical, and so designing for the long term. Basically during your pilots and also like sort of during the prototypes is important, because you need to because information is not as say fast flowing as say in consumer internet, where you get like a bunch of information every day. And so that's why in public health I think it's even more critical to like plan up front and like think about long term from day one. The other point of course is that mistakes are expensive in public health, and it's really bad if you go wrong. And so because it's high stakes, I think being more careful and thoughtful upfront is even more important than say some other domains.
Thank you. Yeah, I think that's a great distinction you've made between public health and other areas. Yeah.
Can I just add I want to add one thing to that. I think when we talk about pilots generally have two purposes. There's piloting an approach, a full approach, and then there's also proof of concept. And one thing that we're often asked to do with machine learning and AI is to prove that it works. And in proving that it works, it's often about the performance of the models. And that can be done in a slightly different way. And then you evolve into, okay, now let's talk about what we're actually deploying. And that's where you have to ask questions, all of these why questions that I think, Pascal, you talked about before, is when you come up with this MVP of what your machine learning model or product is going to be, you have to ask, why is it important? What value is it going to add? Is it actually better than what you're currently doing? And then that's the point where you really start to plan out this pilot from start to finish, where it has to be, the assumption has to be there that you are going to be deploying, because proof of concept is one thing, but it still sits in a very like clinical sterile lab environment. It's not the real world. When you're planning for a deployment, even if it's just at the pilot phase, it has to assume that longer term time frame.
Thank you, Jenny. Yeah, that's a very, very important distinction you made. In the interest of time, I'll move on to the next question. That's for you, Jenny. So if you could share some of the common misconceptions that clients tend to have when you're, building and deploying machine learning models.
Yeah, I absolutely can. I'll focus on two main misconceptions, and we've actually touched on a couple of these, so I'll go into a little bit more detail. And that is that machine learning requires high-tech platforms and complete data. I'm going to be controversial, or maybe not, in this forum, and say that neither of these are true. Sure, clean and complete data sets are excellent resources, but they are not a prerequisite. And high-tech infrastructure is a nice to have, but it's also not required. Of course, again, this is fair for me to say in this forum, but let's talk a little bit about what that actually means in practice. And I'll use the example of our interruption and treatment work. So we have a model and it works. How do we then use that model to improve patient outcomes? Well, we want to get it into the hands of the decision makers, the healthcare workers, those responsible for the interventions with the clients. And we consider different deployment scenarios when we're doing that, such as central versus facility level deployments. And in this case, we didn't have good infrastructure. There was no connectivity between the central and the facility level. Data flowed in one direction. Local deployment was chosen as the best, and at the time, the only possible way to generate output at the facility level, with no data synchronization currently set up. And so we push the ML down to the site and we learn on device. And how is that output received by the end user? On a piece of paper. It is a printed out form. They change one piece of their data query that they already run on a weekly basis. We're not adding a step. That query is slightly modified and it reorders the list for them. So we don't rely on the high-tech devices in that instance. Of course, this did require a lot of back engineering on our side, and it required the engineering team to develop an open MRS module that runs machine learning. That module is then deployed at the sites, and the software and the data environments that we were working with by no means easy. I think I mentioned before they were vintage, but that wasn't a barrier for us. It was a challenge. And if anyone here is an engineer or an ML scientist, they love a challenge, they love a rabbit hole, and it's a really exciting thing for them to solve for. It is by no means a barrier. I also want to touch, of course, on data quality as well, while I still have time. The beauty, and I think we've mentioned this as well, I'd love to hear the other panelists' thoughts on this. The beauty of machine learning is that it can derive insight from incomplete data. It can leverage proxy data as a resource. It can flag inconsistencies in the data that is available. And what this allows us to do is use whatever labeled data that's available to us to infer the data that's not available. AI machine learning in a lot of people's minds is defined by these big organizations, the Googles, the Facebooks, the Twitters, Amazon. And yes, they rely on massive amounts of complete, pristine data to do their work. They absolutely do. It wouldn't work in our context. What they do, their algorithms, their methodology would not work in our context. That's why we do what we do. That's why we have spent years doing what we do. Everyone in this room has figured out how to work with incomplete data, how to work with messy data. It is so incredibly important that we are able to do that. Yes, we're still learning, but we've figured it out. And that's a misconception I think that we have to get beyond, is that we don't need those complete data sets. We don't need to wait for data integration at a national level. There could be 400 different systems. We can bring them all together into those models. Is it more difficult? Yes. Would we like the most up-to-date software? Absolutely. That would be fantastic. Integration would be so much easier, but it's not a prerequisite.
Thanks, Jenny. Those were really important issues I think you've raised. I'm curious, see if Pascal or Meher have any comments.
I'm smiling because I couldn't agree more. I mean, you're spot on. And I mean, the approach that Jenny, you've talked about is exactly what we've used. The only difference is that we didn't have to, translate the machine learning model into a paper feedback form that the healthcare workers use. We have the privilege of having, being able to embed that within the EMR. And that's where I think your point about data quality, I think that's a really big misconception that I wish many more knew about it, that, we've figured out a way of working with the data as it is. And that's where we look at the difference between survey data and routine data. Machine learning, as we've deployed it, uses routine data And routine data, by definition, is not perfect, right? Routine data has, missing values and all that. So being able to figure that out, and the fact that we have machine learning allows us to work with incomplete data, I think that's good, because then it helps us to tackle the next challenge, which is statistical thinking, a statistician's mindset of modeling, and the machine data scientist's mindset of machine learning, which are totally different. Statisticians look at data a bit differently. When you look at survey data, you control for all variables, you control how data is collected. But when you're using routine data, it's a bit different, and you're focusing at you're focusing on the output. You can have data from multiple sources, as Jenny mentioned, to provide the insights that you need. And then the final one is just around model complexity, that you will not be able to fully explain your model every time. And I think that's something that I think it's a misconception that you need to explain every single thing that the machine learning model gives you to explain why is it prioritizing this feature over the other. I think that's a misconception that that needs to be addressed very early as you engage your stakeholders.
I just like to add maybe like a slight counterpoint. It's not entirely. I do agree with most of what I think folks have said. I do think that's important to note that machine learning can't work with every sort of type of incomplete data. So as long as you have like enough signal in the data to make up for the missing values, you're probably fine. And there are like several sophisticated techniques to actually handle a lot of missing data that you might otherwise think is not really usable for training a model. So I think it becomes even more important, I think, to educate our clients and public health folks about what data ML can and can't be built on. But it is certainly the case that like a lot of things that people think are needed are actually not. And you can start building simple and even more complex models even before you think you might be ready. I just like to add a couple of other misconceptions I think I've seen people have. I think a lot of people have this sense of AI being some sort of superhuman magical thing. And in some sense, it does do better than humans in certain cases. But I think it's always the case that you need to have humans in the loop at all stages for the AI model to be useful at all. And it's only as good as the data is trained on. It's not magic. It doesn't sort of know something that, that humans can't figure out. It's basically like this massive correlation machine, right? And so having a human use the AI versus having the AI sort of decide for itself, which we call human in the loop systems, are like really important. It's important for people to understand that. The other thing is I would like to note is that you should only use AI, in my opinion, if it really adds value over pre-existing things to like a significant extent. Because AI systems are not trivial to build or like maintain. They're complex and they're often like not easy to interpret. And so if you can build something a little simpler that does almost as well, you should really consider doing that versus building this complex AI thing that requires money, time, and then like upskilling to like really sort of handle, which is like a big pain. And finally, AI can also amplify issues. So like if there are biases in the data, if the data sort of has some issues that like say privilege one group over the other, a model trained on that will amplify those. And so that's something to always keep in mind for equity and so on when we're building models. Thank you.
Thanks, Mihir and Pascal. And Jenny, of course. We have some questions from the audience. I think some of it was already answered by you, Mihir, when you talked about that, nature of incomplete data also matters, that there should be enough signal in the data. There is one question related to more programmatic issues that can arise. So if you're working with data that is held by implementing partners to implement your solutions and stuff, how do you deal with competing interests?
Yeah, I can definitely speak to this, and I think we're all in the same boat here. Data security is of utmost importance from day one. We go through the correct channels in accessing data. This can require data sharing agreements, data access agreements, MOUs. It can require IRBs if we're accessing patient data. We jump through a lot of hoops, and a lot of hoops for a good reason. They think one thing that we didn't mention when we talked about barriers was like this issue of accessing data, and it takes so long. Like, yes, it's a challenge, but it's so important to do it correctly. And sometimes data access can be the longest part of deploying an AI machine learning model. Now, once it's been deployed, you're often integrated into existing systems. And so that's not an ongoing challenge. Another thing I want to mention there is we generally don't need access to personally identified information. PII is not a requirement. It's not useful. That's not where the signal is for us. Again, the Facebooks, the Googles, all of those, they love it. We don't need it, and we'd rather not have it. And we have scripts in place to de-identify data before it ever reaches our data centers. So that's. I hope that answers the question. I did see another question on there in terms of incomplete data. If I can just quickly answer that as well. Like, yes, in terms of counts, that does work, but in terms of content, it does also work. You can correct data. You can identify where flag where there may be issues and inconsistencies in the data in terms of an error that has been reported. And you can use proxy data to add additional content that may not be available. I'll use an example of, in one instance, we had access to 8% of data. So data from 8% of facilities in a specific environment. That was 8% of facilities had answered survey questions. We were able to leverage publicly available data from building permit sites, from air quality systems, management systems, to infer, using the signal between that publicly available data and satellite imagery, geospatial data, and the 8% of facilities who had actually responded to a survey, to infer for 100% of facilities what those missing inputs should be. So you can also infer content when you have incomplete missing data.
Thanks, Jenny. There is another question in the chat. We don't have time to take it up right now, but if anybody wants to answer it via chat, or if we have time at the end, I think it's a question related to if ML can solve problems related to data aggregation discrepancies, but we'll try and take that up at the end. We do have to move on to the next question we have for our panelists. Mihir, this is for you. So how important do you think is model explainability when it comes to, deploying or ML applications in public health, and how do you approach this when it comes to your work?
Sure. So I think at the outset, one thing I want to lay out is that the reason we need model explainability is obviously to make interventions and to understand why a certain prediction was made. However, part of the promise of AI is that it can do things that a lot of simpler models can't. And by design, that means that you often have models that are more complicated and harder for humans to understand. And so there is sort of this tension where you want to build better prediction machines, but better prediction machines might not be so easy for us to understand, because if they were, we could probably do it ourselves, right? So that I think that sort of sets the stage for what I'm going to say, which is that interpretability is always important. It's often not always necessary in a complete sense, but it's often useful to understand why a certain prediction is being made, typically to do the intervention. I was recently at this ML for Health symposium, and I want to sort of summarize the takeaways from three very experienced keynote speakers. The first two of which described an explanation method, B, a very detailed sort of user state to understand how the explanation method works, whether it breaks, and how it where it actually works. And it was very clear that interpretability is something that you can sort of build techniques to do, but testing whether the interpretability method actually works is its own sort of science, where you design user studies, you design sort of interview questions, you try to understand whether the model, what it's saying, whether it made sense or not. And then the third speaker was much more skeptical than the first two, and he described certain case studies where certain interpretability methods for understanding complex models would give completely different explanations for very sort of small perturbations in the data. And what that means is that oftentimes interpretability methods can't fully be trusted. It's often, I would say the right way to use an interpretability method is as a heuristic. So you sort of see what it tells you. Say it tells you some important features. Now what you do is you go and sort of dig into those features. Use it as a heuristic, not as sort of a gold standard ground truth. Because like I said, if things were so easy to understand, then probably we wouldn't need an AI algorithm. I'd say in terms of the types of interpretability methods you can use, there are two classes. One is global, that try to these methods try to understand what the model is trying to do at a global level for all sort of patients. And there are the local methods that try to see for each patient why a prediction was made. One thing that we've been spending a lot of our thought on is we have our interpretability methods implemented for our project, both global and local, but it's impossible to know a priori whether they make any sense at all. So we've been spending a lot of time actually designing tests in our pilot to understand whether these interpretability methods make sense or not. And hopefully we'll be able to come back with some more detailed analysis of how to use these. Because my current understanding after attending this conference is that people still don't really know how to go from an on-paper sort of explanation to an intervention. Because as I said, it's not always clear how much you can trust these methods. So that's where I'll stop. Thank you.
Thanks, Mahir. That was very useful. I'm curious if other panelists have any follow-up comments. I would love to hear a little bit about the method that you have been testing for interpretability. But yeah, let's hear from the other panelists first.
Yeah, I agree. It's very hard not to agree with you guys. Interpretability is so important. I think that explainability can be a challenge at times. Just going back to the question, and this is something I think, Pascal, you mentioned as well, that explainability, when you get into the very technical aspects of everything, and sometimes when you're talking about unsupervised machine learning as well as supervised machine learning, you get to a point where people start trying to derive insight on causality instead of really trusting the output, because causality shifts over time. So if it were a single snapshot, this signal could be correct now, but it may not be correct in the future. And that's really important. So explainability is not just about explaining the different components of the model and the data that goes in and what we're doing with that data. It's also about understanding how machine learning works. And I think that's at least at a high level, that's something that we need to be really good at doing, is explaining that, like machine learning 101. But the interpretability is so important because the technology works. The technology isn't a problem. We know it works. How it's then put into practice, how the output of that tech is actually used, is incredibly important. And even without AI and machine learning, data isn't put to use as much as it should be. If you add in this component of something that people may not fully understand, that is new, then you add this level of uncertainty in the data that they're accessing. And it's going to take time to build trust that these models are actually delivering improved outputs. But it's really important that that end user understand what they're being given, understand how it's being generated, understand that it's coming from a place of improving data quality in order to improve decision-making and data use. So yeah, I just think at every single level, it's really important to be transparent, but not to over-explain.
Yeah, that makes complete sense. Pascal, do you have any comments?
Yes, I fully agree with my fellow panelists. I think the underlying question here is the question of trust. You want to build trust with your end users. You want to build trust with all your stakeholders. And for that, then you must address fear, uncertainty, and doubt. And for us, it's been a journey. I can't say we've fully cracked it. There's different layers of engagement to build trust with the technical team, the statisticians. You engage them and look at using LIME and SHARP analysis to explain your models. That may work for the statisticians and the technical teams, but it might not work for the end user. So how do you package it in a way that can be easily consumed by the frontline health worker? And for that, if you're looking at an IIT or loss to follow-up use case, you're looking at probably taking top 5 features that were prioritized by the model, so that as a healthcare worker is seeing a patient, right in front of them, they can see that this person is at risk of becoming lost to follow-up because of the following 5 features. 1 is that they missed their last 2 appointments. 2, the adherence is not good. 3, so that you have something, a package of information that you present to the health worker that makes sense. But then finally, the way we deploy machine learning is not in a way that screams that this is an output that's from a machine learning model. It's embedded within the system. And they don't have to take the recommendations from the machine learning model. So for instance, if someone is flagged as potential loss to follow-up, it's the prerogative of the clinician or the healthcare worker to disregard or to use that information. So we don't force their hand to have to use the outputs of machine learning. So I think building trust.
Yeah, sorry, I will have to cut you off. We have 10 minutes, I think 11 minutes 10 minutes to go. Meher, if you could talk about in 30 seconds, an example of the interpretability testing that you've been doing.
I think Pascal, in fact, described two methods called LIME and SHAP. These are like local ones. LIME tries to approximate an experimental model for that data point. And so it's like a linear model in that region. The other global methods are something like permutation feature importance, where you like basically scramble a feature and see how much performance dips. And that means if it dips a lot, it means the feature is more important. So there are examples of both local and global methods, which are per patient and like overall level explainability. Thanks.
Wow. Thank you so much. That was less than 30 seconds. So we have a little under 10 minutes for this last question, which is for all the panelists. And I'm very curious to know what you see as, where do you see ML in public health or global health going in the next 5 years? So I think we're going to reverse the order of the first question. So Meher, you're up first.
Cool.
And I think you all have about 2 minutes per.
Cool. I will start with my most recent experience, which was last week at the ML for Health conference. I think it was a great place to see sort of basically answer this question. I saw a lot of techniques. I saw a lot of excitement about using ML for public health. I think there's a lot of excitement, especially in certain domains such as medical imaging, EHR or data, and so on. However, I was struck by the fact that there were not a lot of projects that are actually anywhere close to deployment or anywhere close to even partnering with someone to deploy. And so while a lot of machine learning folks are interested in applying their sort of skills and their new techniques to healthcare, I do think that there is a gap between sort of perhaps the public health or like the medical community in accepting, at least for I would say anything close to deployment. I think there's a lot of potential, but we still have a bunch of sort of bridges to cross to actually get to achieving potential. Obviously, data is everywhere. Everyone is excited about doing pattern recognition and like doing smart things with data. But I think a couple of things are key. One is it's important for tech folks and tech organizations to partner with the right sort of people. So like either it's governments or it's hospitals or maybe even like clinics to start piloting and then like have a plan for deployment. Because as anyone in tech knows, sort of the technology is or like the model is a very small part of like the whole puzzle. So I think that is key. And the second thing I think is like understanding how to both evaluate and like obviously evaluate the model, but also design the solution. So our paper got like a lot of attention. And one thing, and the reason I think one key reason was that we were in fact unique in the sense that we had like a careful and like robust evaluation, and we had like a part to deployment. I wouldn't say that the work was like technically sort of the most innovative or like the most crazy algorithms, but the fact that we actually had thought through how to evaluate and also a deployment pathway, I think was key. And so I think in the next 5 years, I'm hoping to see more robust evaluations beyond just sort of toy data sets and standard metrics, but actually designing a technical solution with an eye to deployment from day one. And also, I'm hoping to see governments sort of push more to involve sort of technical expertise in leveraging the amazing power they have within their data. So those are my 2 cents. Thank you.
Thank you. That's a great point, Meher. Jenny, do you want to go next?
Yeah, absolutely. So machine learning and public global health in the next 5 years. Well, first of all, it's already here. It's really important to say that machine learning is already here and it already learns from our data. And that's not just in the context of global health and day-to-day life multiple times a day. If you own a phone, if you're using the internet, machine learning sits within that platform and it drives our use of these devices and it improves our user experience. And that's a really important point. It improves our user experience. And the same can be true in global health. but it also requires regulation. And I think everyone in this panel probably agrees that data has to be protected, and it's a priority for any deployment of machine learning at every single step. So we recognize the value of machine learning in improving user experience, in optimizing our supply chains, in improving access to health services, in improving equitable access to health services. We also accept that we have to protect data, and there is a lot of challenge in that. And I'm really impressed over the past few years, actually, on how data protection has been at the forefront of all of this, and how we work with de-identified data. And I think that's going to continue. And I think that we're going to see smarter regulation as opposed to blanket regulation. And I'd like to see that continue as well, so that regulation doesn't become a barrier to machine learning and AI. It becomes an enabler. And that's really, really important. I think we're going down the right path right now. And I'd like to see that we continue to go down that right path. Also, in the next 5 years, I think we'll see machine learning moving away from a proof of concept, project-focused approach towards full integration into health information systems. And that's also really important. We need to move away from the proof of concept, the pilot, towards, okay, how are we actually going to have this just be an integral part of every health information system? We've digitized everything. Now let's use that data. Let's really put it to work. And I think that it's important that we be ready for that shift, because it's already happening. So we have to be future forward in our thinking on the systems that we're building.
Thanks a lot, Jenny. Pascal, you're the last one up.
Yeah, thank you. And thanks to the other panelists, very good insights. I think I just want to emphasize the note on just awareness. I believe in the next 5 years, we'll have improved awareness. Machine learning by nature demands multi-stakeholder approach, different specialities on the table to think of sustainability deployment right from the beginning. So I see that happening. The second thing I see happening is that increased demand from the program teams. In Kenya, we are seeing a case where the program team now wants machine learning as part of the program priority for the coming year, utilizing machine learning for improved tracking of IIT and a version of the same. So I think I see that happening. The other is basically the curation and availability of global goods around machine learning use cases, with exchange of experiences across countries and cross-learning, South-to-South collaboration. I see that happening a lot more, just along the lines of demystification. And then on the deployment side, I see the adoption of ML ops as a practice. On the software development side, we adopted DevOps as a practice to tackle a number of challenges on deployment. And I see ML ops becoming a practice that is well accepted in public health space. And then finally is around usability. I see a better approach on embedding machine learning models and the outputs in clinical decision support systems and the clinical flow. And that's something right now that's still in the nascent stages, but I see that maturing with time. Thank you.
Thanks a lot, Pascal. I think we have less than 2 minutes remaining, but this was extremely insightful. I think hour that we've spent talking about all your experiences. Since we have 2 minutes, I do want to take up the last question that we received from Jacodia. Do any of the panelists have experience in using ML to map data between different digital health systems, operational and field? I'm not sure if they're referring to patient level data matching or curious if any of you have.
I can take a shot. We've explored sort of contextualizing our data with India, the NFHS survey, which is like this survey, massive survey of like households that gets like a lot of sort of aggregated information about like a lot of sort of geographies. And it's not been as easy as we have liked, because essentially what happens is that the schemas for different databases are different. And so, for example, the sub-district names or like the recognized subdistricts stay in our database, NICSHare, which is the central TB database, versus the corresponding sort of thing in the survey data are different. And so a lot of work actually goes into like joining the two databases and understanding where there might be a mismatch, and like making sure that like the right row maps to the like in database one maps to the right row in database two. And so we did like a bunch of work there. It ended up not helping the model too much, but like going through exercise was very helpful. I think understanding the fact that like there are different sort of systems of knowledge maintenance in different digital health systems, and it's like much more work than I think I'd have imagined. I don't know if that's helpful, but that was our experience.
No, thank you. That makes complete sense, and I think that's something we also often face. That you have all these routine national level surveys that are conducted by either the national government or USAID, and then you're trying to combine all of this public data with whatever you might have directly from the government, and it's never easy. But of course, it can be done. I think yes. So the live stream has ended. Thank you everyone for joining this call at 2 a.m. Eastern time. This was a fun opportunity to talk to all of you. And I guess I'll just enter in the chat. People can reach out to us directly via email. But thank you so much.
Thank you.
Have a good night and have a good day, Bob.